And when do we want to
And I'm letting you,
start?
I will
Give
let
people a few
everybody
more
in.
minutes.
Yeah, yeah, a few
Okay.
more minutes.
That looked like what I wanted to share.
Hello, everyone.
Oh, good. Now they can't hear me, right? Till I take off that thing at the
Well, hello, everybody. I think we'll give another minute or two maybe to allow people to come in for setting up expectations and so forth. We request that everybody mute your microphones so there's no interference with the presentation. Um, and there will be a time for question and answers at the end. If you would like to type a question into the chat, we will try and make sure that that gets addressed. And please feel free to do that at any point through the presentation. So one more minute and we will start the meeting. And excuse me, I forgot to introduce myself. I'm Jack Johnson. I'm the Vice President, Americas and Global for the Fabry International Network. Okay, I think we will go ahead and get started. Again, please keep your microphones muted until the end of the presentation. Also, if you want, you can turn off your video if you're having some latency or anything that may help the connection speed at your end. But if you want to keep your video on, that's of course is perfectly fine as well. So I'd like to introduce Dr. Robert Hopkin. He is from the Cincinnati Children's Hospital in Cincinnati, Ohio, which is in the Midwest region of the United States. He is an expert in Fabry disease as well as other conditions. He is a geneticist by training and has been very involved in Fabry for many, many years, treating patients and also participating in research and many of the medical meetings, registries, and so forth. So very experienced. So, Dr. Hopkin, I turn it over to you.
Can you guys see my slides?
Yes.
Okay. So the slides are going to be very simple. You may or may not want to pay attention to them. But basically what I did for this talk is to go through the presentations at the World meeting and pick the ones that I thought were most interesting or had most clinical importance. I did that for some of the posters, but for several reasons was not able to get as deeply into the poster presentations as I had planned. All right. This first thing is a breakout symposium that was sponsored by Takeda, and it's called Fighting Fire. It was focused on inflammation as a driver of Fabry disease. So the three presenters are listed above. pain is one of the most common manifestations of Fabry disease, and it was sort of the main focus, at least the main thing I wanted to talk about that they touched on. So in Fabry disease, there is substantial accumulation of GB3 in the dorsal root ganglia. So those are the clusters of nerve cells that are just outside of the spinal cord. Oh. Trying to get this presented more appropriately. Just a minute. Okay, I'm gonna stop sharing and try to get this fixed. What are you seeing now?
Now it's perfect.
Okay.
Yes, we're seeing
Sorry
the first
about
slide
that.
and it's perfect.
Okay, so the accumulation of GB3 along the dorsal root ganglia is high. There are ganglia along each of the roots where the nerve roots come out of the spinal cord. And small decreases with treatment, with the current standard treatments, there is a little bit of change in the amount of storage, but for that to be evident, it takes 2 years or more. Animal data looking at how Fabry disease works indicates that the neurons are more twitchy than they should be, meaning they fire sooner and more strongly in mice with Fabry disease than they do in mice that don't have Fabry disease. The same thing is true in humans where it's been looked at. And that is thought to be a contributing factor to the pain in Fabry disease. So it's also known that the GL3 or GB3 leads to activation of complement, specifically to complement 3 and complement 4. Activating those two leads to activation of TNF alpha, which then produces a more complex group of inflammatory chemicals. And those are thought to also contribute to the early firing and to the pain of Fabry disease. So people have been then trying to look at, are there ways that we can disrupt that process? And there are a couple of genes that were emphasized in this particular talk. And one of them is TRPV1. TRPV1 is a gene that codes a protein that's a pain receptor and a heat receptor. If it is overactivated, then you feel burning sensation and pain, and it is consistently activated in classical Fabry disease. So that one is thought to be a potentially targetable place because it looks like its overactivation leads directly to increased sensitivity to stimulation that is perceived as heat. And that could be from nerves that are firing appropriately because you're touching something hot or something warm, or it could be neurons that are firing inappropriately because they are primed to fire and are triggered too easily. So there are people looking at ways of targeting that to decrease its activation. Another one that would be, I think, a complementary treatment is the gene TRPM8, which is a cold receptor gene. Now, overactivation of that one can also lead to pain perception. But in people with Fabry disease, TRPM8 tends to be underexpressed and underactivated. So activating that gene for somebody who is feeling burning pain tends to provide a cooling sensation, which leads to a decreased perception of pain. Now, that has not been specifically studied in Fabry disease as far as I know, but in the preliminary data that they presented in the mice, this increased activation looks like it can also mediate the neuropathic pain of Fabry disease as a good target. So that gives us 3 different ways that have not been well studied at this point, but that in theory could be helpful to try to address the pain associated with Fabry disease. One of them would be targeting the inflammatory cascade by using inhibitors of complement 3 and 4 or inhibitors in the TNF alpha pathway and trying to decrease the inflammation. The other 2 would be to decrease activation of and expression of TRPV1 and to increase activation and expression of TRPM8. Now, I found that very interesting because I have been looking for years for new ways to think about Fabry disease pain, and I have usually come up to very vague things, and this one had some very specific things to look at. So this is what I just went through. So bottom line is we are learning a lot more about the biology of pain. in general and specifically about the biology of pain associated with Fabry disease. Hopefully, this will lead in the next few years to better targeting of pain. Okay. There wasn't a lot of other discussion on pain that I could find, but there was quite a bit on heart disease. So this is a paper that's been published, but that was referenced several times. And it is looking at the impact of treatment of Fabry disease and how does that impact the heart. And what they did was dig into the available data of all three of the well-established forms of ERT that are available in Europe, in the US, and other parts of the world. And they also looked at chaperone therapy. And what they found was that being on treatment generally appeared to improve stability. And sometimes, depending on the timing of institution of therapy, sometimes would also contribute to a partial regression of hypertrophic changes in the heart. So the heart muscle would get a little thinner. They emphasized in this that earlier treatment after the initiation of hypertrophy worked better than treatment for longer term or established hypertrophy. Now, I think that the best option here would be to treat before we have hypertrophy, but to do that, we would need to be able to predict who is going to develop heart disease and who may not. Which gets me to the next point, cardiac organoids. So organoids are miniature organs that are being used more and more for research and trying to understand how a given disease affects a part of the body. So in the case of cardiac organoids, they take multiple cell types that are in the heart, including cardiomyocytes, the ones that do the work of actually contracting the heart, blood vessel cells, and then the cells that conduct the electric signaling through the heart. And they culture those together and they get pulsating little bundles of muscle and other cells. And then they can study them and look at the interactions between the cell types and at how adding various chemicals or drugs to the culture media and to impacts the function of the heart in those cells. Now, this is very exciting because it gives us a powerful tool that can help us to make more rapid progress in studying how the heart is impacted by Fabry disease. Unfortunately, at this presentation, most of it was how they developed the organoids and what they plan to do with them in the future, not data that we can apply decision making to at this time. But this is still, it gives us a powerful new tool to learn about one of the most important organs associated with Fabry disease. Another heart one.
Yeah.
4DMT is a
sure?
company.
I have something supposed to be wrong. No, I just woke up startled Saturday morning thinking you turned in your letter resignation. Oh, I was like, she better not.
Peterson, you're unmuted.
Okay. So 4DMT is a company that has been working on cardiac targeted gene therapy for Fabry disease. And they had two presentations on the heart at this meeting. One of them was just follow up on the patients that they had previously treated. And what they found is that the 5 patients that they followed up on have been clinically stable, are continuing to produce enzyme. The enzyme is produced within the heart and kidneys, so it doesn't have to come out of the liver and then go through the circulation. It's made in the place, at least in some of the places where we want it to be. And the patients appear to be doing well. We don't have time to go into all of the details of that, but that's good news. The other thing that I think is important, though, is that this treatment, this targeted treatment, has been on hold for a few years now because of strong inflammatory reaction to the capsids when they delivered the gene therapy. So what they have done about that is they have developed a new anti-inflammatory pre-treatment that they think, and then including some ongoing treatment while the gene therapy starts being active to keep the serious side effects of too high of levels of inflammation. So again, exciting steps forward activity, but we don't have any new data at this time, except that the patients that were treated previously who did not have too much inflammatory response are doing well, which validates the concept. And now they are hoping to reopen the clinical trial with the new anti-inflammatory treatment. Okay. Now, inflammation as a separate issue within the heart, not related to the treatment, but just to the progression of the heart disease itself, I think is one that's really important. So this abstract was presented. They had looked at interleukin 18 and then P4244, MAPK, INOS, and alpha SMA, which are all pro-inflammatory biomarkers. They are not specific to Fabry disease, but they tell you if they are elevated that there is increased inflammation. And what this study did was look early in Fabry disease before there was evidence of cardiac hypertrophy, before there was evidence of cardiac rhythm change, and even at a stage where if they did heart biopsies, they could not see inclusion vessels. So they didn't see storage in the cells. And they looked at a couple of things. One is, was there increased GL3? And what they found is that there was evidence of increased GL3 in the cells well before you could see the inclusions. You also saw consistent elevation of the biomarkers that they looked for, and they proposed that this indicates that you can have significant cellular level damage, some of which is likely to be irreversible at the early stages of Fabry disease before you have inclusion bodies in the heart muscle and before you have seen any changes in the structure or function of the heart using the standard methodologies. So if they are right on that, and this needs more research, that is very important because that would push us to needing to treat much earlier and more aggressively than we currently are. This is another inflammation-related heart abstract, number 153. You'll see lots of genes listed up here, IL-2, IL-10, TNF-alpha, and IFN gamma were all elevated consistently in patients in the cardiac tissue of patients with Fabry disease. IL-1 alpha was elevated in females with Fabry disease, but not consistently elevated in males. MCP1 and TNFR2 were elevated in males, but not consistently elevated in females. And then you have IL-2 and MCP1 being more consistently elevated in females if they have hypertrophic changes in their heart muscle, and IL-6 and TNF-alpha associated with hypertrophy in males. Now, you do not need to remember any of these specific genes. The point that's important here is that, one, inflammation appears to be probably the key driver of the heart changes in Fabry disease. That has important implications for the care that we provide. Two, that there were distinct differences in people depending on the stage of their heart disease, and there were differences between the sexes about how their bodies responded to the storage and which pathways were activated in the inflammatory process. Now, clinically, there are some important differences between men and women with Fabry disease. In men, almost everybody will eventually get heart disease. Almost all of them will have hypertrophic changes, meaning thickening of the heart muscle, as one of the early signs of heart disease. In women, it's not quite as high, although not a lot lower, that they will develop heart disease, but 20 to 30% of the women with Fabry disease who develop heart disease will develop scar tissue in the heart without thickening of the heart muscle. We have not understood how this works, or even had hints about it. This idea that the underlying biology, the genes, and the activation of the inflammatory system are different between the sexes is a first step toward trying to understand some of that. And then hopefully being able to use a combination of both of these studies to get some better ways of predicting who will have progression of heart disease and thereby being able to predict when to start treating. We also may be able at some point to target anti-inflammatory treatments in addition to the treatment that decreases the storage and make that a more effective treatment for heart disease. Okay, now transitioning to kidneys. Monitoring kidney disease seems simple. You measure the filtration rate of the kidneys, you measure the protein in the urine, and you can tell how things are going. But it's not that simple because the kidney disease progresses very slowly. It may take years to see a change. Furthermore, kidney function and urine chemistries, including proteinuria, are almost always normal in pediatric patients, often normal in young adult patients, until you have lost around half of your kidney's residual capacity. You may have no evidence using the current monitoring protocols that you have kidney disease. And we don't want to wait until you've lost half of your kidney's capacity to intervene if we want to keep your kidneys healthy for a normal lifespan. So we need better ways of measuring the kidneys. So abstract number 19 was an interesting one. So there's been a necessity for kidney biopsies to adequately stage kidney disease in Fabry disease. But that's a pretty invasive procedure, and it's very expensive. It's hard to analyze, takes a lot of time. So they've been looking for other ways to assess this. And this study was on a newer way. So we've known for a while that some of the cells in the kidneys will come out in the urine. Specifically, podocytes will be collected in urine samples in small amounts. And that's a normal thing. It's increased in people with Fabry disease. That's been known for a while. What they did with this study was use a technique called flow cytometry to be able to measure the number of podocytes and to get an estimate of the amount of storage in those podocytes from urine samples, with the hope that it would correlate with the stage of renal disease and with the health of the overall kidneys, and allow us to get the kind of information we need, at least some of the kind of information we need from the kidney biopsies without having to do a biopsy. This was a preliminary stage, but they found good correlation with renal disease, good correlation with the degree of storage that they found on biopsies from the same patients. And they hope that this can be, as they refine the process a little bit and get it more automated so that it can be widely available, that they will be able to use this as a method of tracking change in kidney function and kidney health over time that will be more sensitive in the short term than the calculated GFR and proteinuria are that we use currently. So more to come on this as well. This one is from the same lab. This is Najafian's lab for both of them. But this one was looking at another challenge. I mentioned before that analyzing kidney biopsies can take a lot of time and expertise, can be very expensive, and that has been a big limitation in use of kidney biopsies, both for clinical care of patients and probably more so for the volume of patients that you would need in clinical trials. So proving that we are actually correcting the right cells in the kidney to keep the kidneys healthy has been quite difficult, because you can't find people with the time and expertise to do it, and because the cost of doing the analysis, especially the semi-quantitative analysis, was very high. So what this study focused on was if we use AI technology to assist the inclusion evaluation in capillary endothelial cells, and they also looked at podocytes and mesangial cells and other cell types in the kidney. And they think that it would work in heart as well. Can we get the information? And what they found was that you could, in fact, get reliable information that was reproducible if you had a well-trained AI system, and that could then allow an expert to do some spot checks to make sure that it was correlating appropriately and greatly shorten the amount of time and work, thus also decreasing the expense. And so this is the third time this approach has been presented that I've seen at the World meeting. But one of the quotes from last year, from the guy who presented this project last year, he said that with 10 minutes of AI, you could do 2 weeks worth of work from the standard methods. That's a huge difference. That could make this a clinically applicable approach if we can get it done. I do not know how long it would take to make this available to the drug companies that are doing the clinical trials, but I do think that this is exciting new technology. So this would be more rapid, cheaper analysis. It would improve follow-up of treated patients who need kidney biopsies. At least 3 different clinical trials have been delayed because the companies were not able to find people who could do the analysis at the level that they wanted it done for a price that the companies felt they could afford. So other things in kidneys, kidney organoid development was also described, but not in as much detail as the heart. And multiple speakers noted evidence that earlier treatment is better for the kidneys in providing more reversibility and in more complete clearance of the kidneys. That has been known for quite a while now, has been talked about for many years. So I think we can consider that principle to be essentially proven, but it's not embraced in healthcare system policy yet at a level that really promotes early intervention of treatment broadly. Stroke. This is something that rarely gets talked about at big meetings. So this abstract 42 presented by Berlina, I think was one of the key things presented. So there has been controversy. Stroke has been known to be a risk factor in Fabry disease for a long, long time. But there's been controversy about whether treatment actually changes the stroke risk. So what they did to try to answer that is pull out almost 1,900 pairs of patients. And in those pairs, you had one person who was on treatment and one person who was not on treatment. And they matched them by age and sex as best they could. About half of the patients were male. 68% had classic Fabry disease. 14% had other had late onset, and 17% had other, meaning they weren't classified, or we had mixed data and couldn't classify the variants adequately. The time in the study, the time evaluated for the study was 5.8 years for treated patients and 3.3 years for untreated patients. So the results were that the treated patients, for every 1,000 patient years, there were 5.5 strokes. And this was just the first stroke. If you had a first stroke, then you were no longer included after that. Now, the untreated patients during that, for that same measure per 1,000 patient years, had twice as many. Then they said, well, it has been talked about that heart rhythm disturbance and advanced kidney disease are risk factors for stroke, and some people have proposed that we only see stroke in people with advanced heart disease, advanced kidney disease. Other people have said, well, what about anticoagulation? Does that change the risk for stroke? And does treatment with statins protect against stroke? So they looked at those things. And what they found was that the result, the difference being the risk being twice as high, was preserved when they corrected for heart disease stage and kidney disease stage, and that we didn't have enough patients to really say, but that there was not a notable difference or an obvious difference with the added medicines that are supposed to add additional protection. So what can we learn from this? One, not all stroke in Fabry disease is due to heart disease or kidney disease or other advanced organ damage. Stroke is an independent risk factor in Fabry disease, although it can be complicated if you have AFib or other heart rhythm disturbances. Treatment appeared to decrease risk in this study. Now, this study only looked at 1 milligram per kilogram of ERT, and it did not include the pegylated ERT. So we don't have any data on if the 0.2 milligrams per kilogram changes, or if the chaperone would have equal changes to this, or if the pegylated ERT would. But there's a good chance that they would make a difference as well. We just don't have any data on that. That needs to be analyzed separately. Now, I don't know how many of you have been talked to about hip disease as a risk factor or as a complication of Fabry disease, but avascular necrosis has been known for probably close to 30 years as an associated finding in Fabry patients. It may require hip replacement in some cases. It can be quite painful and quite severe. We need to know about it to have any chance at doing prevention. And in my practice, having hip disease that requires surgical intervention has been strongly associated with more severe lymphedema and with the higher risk for infections and other complications of the lymphedema. Lymphedema being another often neglected manifestation of Fabry disease. So I thought this was a good reminder. It was abstract number 291. Not really new, but something that does warrant attention and that I think patients need to know about. And now on a related topic, Dominique Germain, abstract 105, he presented on lymphedema. Now, he had not seen an association in his practice of lymphedema with hip disease that required surgery. He also hadn't had very many patients who had had surgery for hip disease. He presented a series of patients, both male and female, that had very severe lymphedema with skin changes and evidence of poor circulation in the legs and feet. That's called erysipelas. It is the more severe end of the lymphedema spectrum and can be associated with life-threatening complications. In my practice, I have lost at least 2 patients to that, so I take it quite seriously. It is very difficult to reverse lymphedema once it gets to the advanced stages, but if when you first notice that you have some swelling in your feet, you start doing things like wearing the constrictive stockings or using wraps or getting lymphedema massage, you can prevent the disease from progressing and leading to the point of erysipelas, where you now have potentially very limited mobility and high risk for serious complications. Treatment options. I'm going to go through these fairly quickly, even though they're high interest. Most of this stuff has been presented and discussed in previous years. And in fact, a lot of the topics on this section I talked about a little bit last year. So the ST920 gene therapy trial, sponsored by Sangamo, had an update. They presented updates on 33 patients. Greater than 20 of those have more than 12 months of data in the last data cut, with the longest people since initiation of treatment up to 3 years. The surprising thing here, and I think this is a really good thing, is 33 patients treated with no serious adverse events. Nobody has required hospitalization or sustained immunosuppression. I think there were 2 people who required short bursts of steroids for a few days. And all of the patients that were presented were producing enzyme. Most were producing supraphysiologic levels of enzyme, meaning that there's a good supply in the bloodstream available for uptake by the cells in the body that need it. Several of the patients had high antibody titers at the time they were treated. There was worry that that would trigger immune response and that you might have sustained problems with immune reaction against the enzyme that your body is now making. Fortunately, that has not happened. In fact, what happened in all cases where they had already in place antibodies is that the antibody titers dropped quickly, most to unmeasurable levels, all to low levels. Nobody developed new antibodies with this treatment. Another thing that was really quite interesting is they measured quality of life. They used 4 different scales to measure quality of life, and all of them showed sustained, clinically meaningful, and statistically significant improvement in quality of life. Now, if you had that from only one measure, you'd say, well, maybe it's just a placebo effect. Hope helps people to feel better. But when you have 4 different ways of looking at it, and they've been sustained for long period of time, it becomes more compelling. Another thing that was really unusual is that the filtration rate of the kidneys, or GFR, increased slightly in the population as a whole. That is very, very unusual. So the FDA and the EMA, who are the people who decide if drugs get to be approved or not, are keeping a close eye on this. And what they proposed is that if for the next 2 data cuts, the gains in GFR are sustained, that they will review the data for the study as a whole for an expedited review, which would allow approval of the treatment earlier than had been previously anticipated. Now, there are some areas of concern on this study. One of them is that kidney biopsies and cardiac MRI have been done, but they did not present data from those procedures at this. So I would love to see that because when you have things that are surprising, like improvement in GFR or the robust improvement in quality of life, you want to look at it in other ways and make sure that what you're seeing is being interpreted appropriately. So it looks promising right now, and more to come. It will probably be about a year before we hear a more substantial update. Lentiviral gene therapy was tried, and they treated about 5 or 6 patients successfully. And then they treated the next 8 patients and didn't get successful engraftment. So this study, they went back and looked at the ones that had been engrafted successfully with the lentiviral gene therapy and found that the patients are in fact doing very well. They have been looking for ways to explain why they had lack of engraftment in the next 8 patients and are looking to work with a different pharmaceutical company for another attempt at a clinical trial on this. Some of the potential benefits of lentiviral gene therapy are that with AAV gene therapies, every cell division, you have some risk to lose production, a little bit of production of the enzyme. In lentiviral, because it integrates into the nuclear DNA in the chromosomes, every time the cells divide, you actually increase the potential to produce more of the enzyme. But there could be some risk for cancer. So far in this approach for Fabry disease, there have not been any cancers reported. Other gene therapies, targeted gene therapies that we talked about earlier, using RNA as the vector rather than DNA, that would require multiple treatments, but should in principle have low risk for infusion reactions. And then there's also non-lentiviral ex vivo gene therapies where they collect B cells or stem cells, treat them with gene editing, and then reinfuse them back into the patient. and those are all being looked at. There were not a lot of details presented. They were just mentioned in this meeting. Substrate inhibition, in other words, stopping the body from making GL3. There were at least 3 companies represented at the meeting that are doing that. 2 of them are well into active clinical trials. Venglustat is the one that's the farthest along. They have 2 phase 3 clinical trials that are fully enrolled. They did not give us a data cut. I was disappointed with that. But I do understand why. It's because they just finished enrollment and they didn't have enough data collected yet. ACE Therapeutics is a Chinese-based clinical trial, at least for the stage that they're at now. They presented sort of the preliminary preclinical data, but they are in active clinical trials. But as with Venglustat, did not have enough data collected to present at this time. So the benefits of substrate inhibition: it's oral, it doesn't depend on mutation, gets into nearly every cell type, and it may be useful as a combination with enzyme-based therapies. Chaperones, we're going to skip migalastat and just say that there is a next generation chaperone being developed that is hoped to be non-inhibitory, which would make dosing regimens simpler, and they are specifically designing it so that more variants will respond. Again, very early in this process. Modified enzyme was really interesting for a couple of reasons. One is that the modified enzymes, and there were at least 2 of them that were highly talked about at the meeting, one of which is the pegylated enzyme that was just approved recently. The other one is a fusion protein, but neither of those are being taken up into the cells via mannose-6-phosphate. That different mechanism leads to a lot of interesting questions about how immunogenic will these things be, how long will they stay in the body, and will the tissue penetrance and the activity levels of the enzymes be similar? So we have a lot to learn, but it is clear that they are not mannose-6-phosphate dependent, and both of them at the stage that they are now seem to have decreased immunogenicity compared to the native enzyme infusions. So this HM15421 is the newer of the 2. And that one is interesting in that it is targeting injectable subcutaneous injections so that the patients could self-administer the drug when it needs to be administered, similar to the GLP-1 drugs that are being used for diabetes and weight loss right now. But this would be a once a month injection, and then the hope is that that would suffice to control the Fabry disease for that period of time. The preclinical data is very strong. They are just launching the first clinical trial in people. The pegylated enzyme, again, we'll skip that for sake of time. This is another modified enzyme. This one, what they did is take the native enzyme and encapsulate it in lipid nanoparticles, and that allows it to get into the bloodstream and get to the cells without exposure of the enzyme to the plasma. So should inactivate less of the enzyme, and it could also protect against infusion reactions and inflammatory response with the infusions. Again, very early. The other thing that I thought was really interesting is that this one can be delivered in principle orally. Again, very interesting idea, very early phases. And we will skip this other stuff because we're out of time. All right, I am happy to answer any questions. I will stop sharing.
Well, at this point, I am not seeing any questions in the chat. If there is a question someone would like to ask, they can.
It looks like somebody just posted one in the chat. Do I have a preference or favorite for the gene therapies? I do not. I am quite excited about all of them. I can make a strong argument about each of the gene therapies, and there were several additional companies that are also doing related work in here, and I can make arguments in favor of and against each of them. I think we need at least two preferably distinct approaches to gene therapy to be eventually approved so that we have the ability to choose what works best for the given patient, and so that if a retreatment option is needed at some point, we have more than one option. So I would like to see at least two of them eventually approved, but I don't have a personal favorite at this time.
So another question came up on how big is the risk of cancer potentially?
So we don't know right now. So in the initial gene therapy trials, this was not Fabry disease, it was other diseases. It was very high, more than 50% for the lentiviral associated gene therapies. Since then, they have targeted the integration sites, and they have gotten a lot better refinement in that, and they do the gene therapy outside of the body. They look at some of the behaviors of the cells, make sure the cells are behaving like healthy cells should, and then put them back in. So it's not super high at this point, but how high is it? It's probably higher than background, but not so high that it wouldn't be a legitimate consideration. And in the patients that got expression, actually also in the ones that failed to express the gene, nobody got cancer out of the ones who have tried the lentiviral gene therapy for Fabry disease.
There is another question, David Patton. If you have a question, you could unmute your mic. Go ahead, David. You can ask your question.
Hi there. Thanks. So firstly, thank you, Dr. Rob. That was really helpful, really insightful. I wondered on the pain genes, are any companies at the minute looking at opportunities for targeting those pain genes? Is there anything, or is this still quite early stages in the identification and the sort of process?
So they are talking about targeting them. It's still pretty early for this. One of the things that I thought was very interesting was that there was a proposal made in a couple of the sessions actually on Fabry disease in the symposia, which would be a 2-hour thing with 3 to 4 presenters. But in at least a couple of those, they proposed that we need to get people who are not Fabry experts specifically to be involved with that, but people who are involved with the targeting of those gene pathways for other disorders. And we need to network with them and get their input on how to most effectively do that. There may already be ways of targeting those things that are available, but we haven't used them with Fabry disease yet. So that's ongoing discussion. Should not take as long as the gene therapy trials, for example. Shouldn't be 10 or 15 years from now we get something. It should be much sooner than that. If there are already existing drugs being used that target the pathways.
Okay, no, that's helpful. Thank you. And one more question, if I may, if there's time. The pegylated enzyme, the Fabrio, I believe it is, the one that's currently licensed. Was there much data on the efficacy of that over since
the data on efficacy for that appears to me to be essentially identical to the efficacy of the treatment at 1 milligram per kilogram with the other ERTs, which is a little bit more complete clearance, although we don't know that there's a clinically important difference between that and the 0.2. So it looks like it's probably about equal with the data that currently exists. But clinical trials only give you short-term data, meaning up to 2 years, typically. And we need much longer-term data to be able to sort out those kinds of differences. The place where there does appear to be a difference between the pegylated enzyme and the older enzymes is in the risk for infusion reactions. And it seems to be less with the pegylated enzyme.
Okay. Well, thanks. Thank you.
So we have a couple more questions. One that's been put in the chat, which is, what is the window of opportunity for a Fabry patient who has never received enzyme replacement therapy?
So we don't know that there is a time that they get to when they wouldn't have some potential to benefit from treatment. So I think if somebody, unless they are end stage to the point that they need a heart and kidney transplant and can't get both of those things at the same time, which would be very late stage, that you have some potential to benefit from the treatment. You just have more potential early. So you have a window of opportunity that's going to be optimized treatment. My guess is that the optimized treatment would need to be started before age 10 in classical Fabry disease. We don't know what that window would be for non-classical because nobody has done a large-scale study on non-classical Fabry disease over a long treatment period, so we don't have data on that. It's probably a wider window. And then the longer you go after that sort of optimal clearance window, the more limited the reversibility is going to be.
Okay, and then Julia Alton has a question for you.
Thanks, Jack. Hi, Dr. Hopkin. Thank you. So my question is, we've talked a lot about inflammation being a driver for Fabry. in your clinical practice or in your thoughts, what else can patients do then even earlier to help inflammation and prevent inflammation?
So there's lots of things that patients can do. One is treating the underlying Fabry disease. Decreasing the storage should decrease the inflammation, and there is some data to support that. Eating a healthy diet and getting regular exercise, which actually there were presentations on both of those ideas at this meeting as well. I just didn't have time to talk about everything. But a generally healthy lifestyle and eating foods that are well tolerated and that are not inflammatory. It is likely that targeting some of the inflammation with medications as a supplemental treatment. So right now we use ACE and ARB treatments and SGLT2 treatments to protect the kidneys. We use statins to help protect the heart. And those are not targeting Fabry disease specifically, they're targeting the secondary complications. We can probably do that targeting inflammation, but we have to figure out which drugs to use and how to safely dose them. And we haven't gotten there yet. It is, however, I think a nice milestone that we had open advocacy for taking that on at this meeting by not one or two experts, but sort of the experts as a group. It was something that was specifically focused on in the Fighting Fire presentation, but was also mentioned by probably at least 10 other presenters.
Okay, we can take one more comment or question from Mary, and I think we're going to need to call it because we're going quite over. Anyway, Mary.
Yes, thank you, Jack. Dr. Hopkin, as always, your presentation is always great and very informative. Is there anything that you would expecting to see at World and as a presentation for Fabry, and you haven't, or something that you expecting to to come, in
So I was really hoping for substrate inhibition to have data to present, and was a little disappointed that that did not happen. And what I'm hoping for the future is the ability to look at combinations of therapies, because we have things that are targeting Fabry disease in different ways now. The substrate inhibition is very different than all of the other treatments. All of the treatments currently on the market are dependent on enzyme activity in some way to benefit the patients. The substrate inhibition is just blocking the stuff that needs to be broken down from being made. And so using combinations of therapies like that, I think is very important. The other thing that I had kind of hoped for, but wasn't surprised that it didn't happen, is there are some new animal models of Fabry disease. One that is a rat that has a lot of overlap with the human disease. And I was hoping that there would be some presentations in the basic science on that side, particularly of the central nervous system and pain biology. I'm not given the state of funding and things in the US right now, I'm not terribly surprised that that didn't happen, but it was something I'd hoped for.
Okay, well, thank you, everybody. Thank you, Dr. Hopkin. I believe we had a fantastic job, as always, on presenting your information. Sorry that we didn't have more time because there was always interesting things happening these days in Fabry, which is wonderful to see. And we would like it to thank everybody for your wonderful questions. All very good. So with that,
And
I'd
I
like
would
to-
like to thank all of you for one, listening and helping me to learn, but also just for being actively involved and engaged. We don't know what questions to ask about Fabry disease unless we hear from you. And we can't get to the goals that I have for treatment of Fabry disease without your active involvement.
Okay, wonderful comment. And yes, it takes all of us to be involved to truly make a difference and move treatment for Fabry forward. So thank you for pointing that out, Dr. Hopkin. We look forward to future opportunities to present information on Fabry disease. And thank you again for being here and having your questions. So with that, we'd like to sign off, and until next time,
Have
goodbye.
a good day.
Thank you.
Yes.
Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye.